All right, so if everybody can see, oh, hi, Dr. Obi. So nice to have you with us. Dr. Obi is one of my colleagues. She's one of the other ACOM ambassadors. She's wonderful. Thank you for joining today, Dr. Obi.
Thank you. Welcome,
Awesome.
guys.
hmm All right, guys, so it's 12:01. I want to be respectful of folks' time. So if other folks want to join in, they are more than welcome to do so. But let's go ahead and get started so that we can make the most of the time that we have together, and I can let you guys out on time as well. Give me a moment just to wet my throat, and we will get started. So um, I know that some folks that are on today were here last week, and they were able to join Dr. Crawl for the inaugural webinar that we have. So this is the second in the series. I am Dr. Robertson, and today the title of my webinar is going to be Toxic Skies, Addressing Veteran Airborne Hazard Exposure Concerns. And what we're really trying to do is to introduce you guys to um, various settings in which we practice occupational and environmental medicine. And so next, let me just, come on, behave. So my screen is not wanting to progress. Hold on. Oh, I know. There we go. So I'm an occupational environmental medicine physician. I currently work with Veteran Affairs at the facility in New Jersey at the East Orange site. And prior to that, I actually worked in family medicine. I completed a family medicine residency training program and worked in family medicine for about 6 years. And then I did a fellowship in occupational environmental medicine and worked in employee health for a number of years. And while I was in that program, I worked with first responders who had ground zero during the world after the World Trade Center fell 9/11. So I worked quite a bit with those first responders, and then I started working with the VA, where I work with post-deployed veterans who deployed primarily to the Gulf War combat area during that time. I also see veterans who were Vietnam era veterans and veterans who did peacetime deployments or veterans who've had stateside deployments or duty station concerns. So we'll talk a bit about that. But as you can hear from that, I've had the opportunity to work across various different avenues. In terms of background, I am originally from the South, Mississippi. And I did my medical school training at Brown in Rhode Island. I did my family medicine residency training at Henry Ford in Detroit. I did a locum tenens year in South Carolina where I worked with rural health. And then I did my fellowship training in Rutgers in New Jersey. So quite a bit of traveling and getting around. So I enjoyed it quite a bit. My disclaimer: the views expressed in this presentation are mine. They do not reflect the position or policy of the Department of Veteran Affairs, and I have no conflicts of interest to disclose. I'm required to say that. Okay. So, in terms of a little bit of an outline, what I like to do here is I like to do a little bit of an overview of what military environmental exposures typically come up during the course of the evaluations that I do. Talk a bit about the adverse health effects associated with those exposures, and then I'll share a bit with you about the Airborne Hazards and Burn Pit Center of Excellence, with which I work, and I'm the clinical director of that program. I'll share with you a little bit about some of the studies that we've participated in, and then I'm going to introduce to you a new entity that we have been able to participate in, known as the deployment-related respiratory disease, and then I'm going to end it with talking about some treatment recommendations in regard to exposure-related health concerns. So. All right. So we're going to start out with a little bit of a case, and I constructed this as kind of what you would see, no matter what area of medicine you go into. You guys will be seeing patients, right? You'll be seeing patients that will come into your office, whether you go into primary care, family medicine, internal medicine, pediatrics for that matter. Although this probably won't be a scenario you'd see much in younger folks, but even in specialty clinics. You're going to have patients that'll come in and you're going to get a history. So here you have a patient whose chief complaint is some difficulty breathing. So it's a 57-year-old male who just moved to the area and he's coming in to see you as a new patient to establish care. And he wants to know if you can help him with his breathing. So, in terms of his history, his past medical history, his asthma, his hypertension, allergies. He's no known drug allergies. He's on lisinopril, Symbicort. He takes Zyrtec and albuterol as needed. In terms of his family history, his mom has lung cancer. His dad has hypertension, diabetes. He has brothers and sisters, but they're pretty healthy. He's married with 3 children. He's never smoked. He tells you he drinks socially, 2 to 3 drinks on the weekend mostly, and no history of drug use. He works as a mechanic. And because you've taken this lecture, you happen to ask him, was he ever in the military? He tells you, yeah, he was in the Marines and he deployed to the Gulf War region. On physical exam, he's in no acute distress. Vital signs are pretty stable. And his physical exam overall is within normal limits. No significant. Um, Respiratory abnormalities noted on his exam, although he does tell you that he feels like he has a hard time catching his breath despite taking the medications that he's been described. So that's what you're seeing in terms of what's presenting in this evaluation. So what do you do with that? So I like to start this talk off with giving you some background in terms of the military aspects of it. So this is just a real brief overview of the Gulf War conflicts, and they typically start out with a brief summary of the timeline that starts out with the Gulf War era with Operation Desert Shield, Desert Storm, and those are the two that people are typically familiar with. That started in 1990, 1991. And then that was followed by a brief stint in Operation Southern Watch. And then the ones that people are also familiar with, Operation Enduring Freedom, which was in Afghanistan, followed by the Iraq Wars, Operation Iraqi Freedom, and then Operation New Dawn. And then here I want to present to you a little bit of a graphic. So this is a real high level overview of the areas where the Gulf War region, where the conflicts were fought in the Persian Gulf region. So these are the areas at one point or another where the veterans would have deployed during either of those conflicts. So some of the areas that may come up as you're talking to veterans who may share with you the places that they deployed. Now, this is one of my favorite slides because it can be overwhelming when veterans are talking about exposures or active duty members for that matter, when they're talking about military exposures. It can be overwhelming. And when I first started at the VA, it was overwhelming, despite the fact that I was very familiar with how to address exposure evaluations because I had done the fellowship and I knew how to address them. But just trying to identify individual exposures um, can be a bit much and can be overwhelming. And so the way we tend to think about exposures is in categories. So we typically start with the category of physical and psychological exposures, and that would include anything like heat and cold injuries, explosions, musculoskeletal injuries. We think of excessive weight as an exposure, and loud noises as an exposure, as well as psychological and mental stressors. We know that being in the military changes you. So the trauma that creates, we think of that as an exposure. The second category of chemical hazards. Most people think about solvents, fuels, depleted uranium, paints, pesticides, as well as chemical weapons. We think of those kind of chemical hazards as exposures. That's probably the one that people are most familiar with. The third category we consider is prophylactic measures, and these are actually exposures that are meant to be protective. So, vaccines, anthrax vaccines, smallpox vaccines, anti-malaria prophylactic medications, as well as pesticides. The fourth category, biological. So, anything like insect bites, animal bites, any exposure to blood and bodily fluids, as well as biological weapons. And then last but not least is the category of airborne hazards or respiratory irritants, which is really what we're going to be talking about a bit more in depth today. So when we look at these categories of airborne hazards, the ones that tend to come up the most tend to be burn pit smoke, sand and dust, or oil well fires. And I imagine that you guys have probably heard about these to some degree or another. So I'm just going to spend a little time talking about each one individually. So when we think about burn pit smoke, this is the one that I think most people are familiar with, and it was really came to attention because when folks came back from their deployments, there were a lot of stories about being around burn pits during the Gulf War deployment. And the thing about burn pits is it's not a new phenomenon. Burn pits have been used in times of military conflict for many, many years. The issue around the Gulf War conflicts, though, is that the volume of burn pits that were used, and that was because it was associated with the volume of military personnel that was deployed. And this was of particular note on a place like Joint Base Balad, where there were over 15,000 personnel that were stationed at that one base, and they generated up to 200 tons of waste per day. That's a lot of waste, and it had to be gotten rid of. And the way that they typically got rid of waste during military conflicts was to burn it. And when we talk about burn pits, what we're really talking about is these large open air areas of incineration. And when I say large, I mean as large as football fields, one, two, three sizes, depending on how big the base is and what needs to be burned. And at the height of, these military efforts, at one point there were up to 273 burn pits in Iraq and Afghanistan alone as of August 2010. So that's a lot of things that were burned. And we know that in terms of what they were burning, it was any and everything from military equipment, hospital equipment, um, human waste, animals, bodies, anything that needed to be gotten rid of was thrown into these pits and set on fire. So this is another exposure that can come up is smoke from the oil well fires. So at the end of the first War, more than 600 Kuwaiti oil well fires and several pools of spilled oil were ignited and left burning by Iraqi troops as they were retreating. And there were these huge plumes of billowing smoke that could be seen rising into the air, partially obstructing the sun at time. And it was so dark that veterans would say that it looked like nighttime during the day. It was so black. And this is a particular exposure because when oil is in the air, not only is it difficult to see, but you have these particles that can coat your skin. And when it's coating your skin and you're coming out of that, that is a very uncomfortable type of exposure. And people, even if they're flying through the area, if they're in aircraft, these types of exposures can even get into the aircraft and be a source of exposure. Sand and dust. So another source of exposure that is often overlooked is sand and dust. And if you can look in this background and you take a look here, you can see the buildings and in the foreground. Let me see if I can do this. You see these here, these are trucks, right? And these are barracks where people lived. And all of this is a sandstorm. And I always like to liken it to, if people ever saw that movie, The Mummy, how the sand will roll in, and it rolls in that fast. If you're out here and this storm rides up, you can't get out of the way, and it comes in so fast that and it's so thick that it's hard to see, it's hard to move, and the particles are so very small that people called it like talc like powder. It's so very fine that the wind picks this sand up off the ground and turns it into these storms, and as it rolls across the fields. And it they would say that these storms could last anywhere from a few minutes to many days, and they were really frequent, with some reports suggesting that a dust event could occur, one in every 3 days. And when they hit, it was really just impossible to see or even be outside. And then, of course, there were other sources of airborne hazards: industrial, airborne pollution, aircraft, automobile engine exhaust, aerosolized particles from explosions, blasts, structural fire. And not just that, but from industry in this area. There were still, buildings and factories that were about the business of doing the work that they were doing. And there was no EPA there, so the levels of protections in terms of managing air quality is not quite the same in some of these areas of the world. So the just air quality in some of these areas just added to this phenomenon of air issues. So now we talk about these exposures. The next question that veterans tend to ask is, okay, so what does that mean for me? How will these exposures affect my health? And the answer is, well, it depends. Now, that's never a satisfactory answer, but that is the answer. And so there are a number of factors that we have to take into account. And I think you guys talked about some of this last week with Dr. Crawl as I was revisiting some of her slides. But from a military perspective, we try to break it down again into, kind of categories. From an environmental perspective, what we really want to know is, well, what were you exposed to? When were you exposed to it and how much were you exposed to? How long was that? In addition to that, what were your other military duties? And it's very important to ask, what was the route of exposure? Because the route of exposure matters. We know that when veterans are exposed to a chemical, how you're exposed to that chemical often determines what type of symptoms you will have, especially in the case of something like solvents. When you're exposed to a solvent, if you're exposed dermatologically, if you have a solvent that you're exposed to as a substance on your skin, you're going to get different symptoms as to whether or not you're breathing the vapors of that solvent in. So you're going to get different symptoms depending on how you're exposed to the chemical, right? And also whether or not there are mitigating factors. So if you have on protective equipment when you are having exposure, that's also going to protect you to some degree as to whether or not you get symptoms. So simply being in the room with something does not necessarily mean that you're going to have symptoms or that you're going to be ill. And your own individual factors also make a difference. Some people may be more inclined or may have a genetic makeup that predisposes them to get ill versus others. If you have other lifetime exposures or other individual habits that adds to your exposure, that makes a difference. And if you have other health conditions or illnesses that impact you, but this other one, this is also one that's really important to think about, the dose. And I really like this particular quote, is that the dose makes the poison. And this is a pretty famous one from Paracelsus. All substances are poison. There is none that is not a poison. The right dose differentiates a poison from a remedy. And what this really means is you can be exposed to a chemical, right? But is the dosage sufficient enough to cause harm? And that is an important question that needs to be asked. And so oftentimes what we will see in the specialty of occupational medicine, especially one, if they see their primary care provider and they're not as well versed in the area of occupational medicine, is the patient may say, well, I was exposed to, I don't know, a nerve agent, and now I have this problem. Do you think that exposure caused this problem? And I think the knee jerk reaction tends to be, well, maybe, probably. But there's a whole lot more conversation that needs to take place around that. And probably the biggest one is, well, how much were you exposed to when you were exposed? And then the next question has to be, what symptoms did you have? So always remember that in mind. So the takeaways from this is, not all exposures are toxic. Individuals respond to environmental exposures differently. Not everybody responds the same way. And then presumptions. We're going to talk about presumptions later, but presumptions do not take into account individual monitoring. It's a VA technique or tactic that's used to try to address the idea that we don't know what levels of exposures every individual had. And last but not least, association does not equal causation. So just because you were exposed to something, that does not mean that exposure caused the disease. Okay, so now I'm going to change gears a little bit, and I want to talk to you a little bit about the Airborne Hazards and Burn Pits Center of Excellence, and that's where I work. And what we do is we specifically, our efforts are in trying to better understand the long-term health effects associated with exposures to those airborne hazards through research, specialized evaluations, as well as education. And the reason this started is because once veterans started returning back from the Gulf War and coming into VA to seek help, one of the first things that was noticed was that these veterans reporting increased rates of respiratory symptoms, coughing, wheeziness, shortness of breath. It was seen in these post-deployed veterans. And this was also correlating with increased rates of diagnoses of things like asthma. And you can see here in this graph where we were seeing these increased rates of asthma. And so when asked about exposures, the exposure that seemed to keep coming up was burn pits. So the question became, Is exposure to burn pits increasing the risk of adverse health outcomes, specifically as it relates to asthma? So this was one of the studies. One of the first studies that was done was to specifically look at veterans who worked at burn pits, specifically at burn pits, and their whole job was to man the burn pits. So their job was to throw the trash in. They would um, put the gas on fire or the jet fuel on fire, stir it up, and their whole goal, they had to stay there. They worked in shifts, anywhere from 12-hour shifts at a time, multiple days at a time, or sometimes they'd do a shift once a week and then come back, but they had to stay there the whole time and experience that elevated level of exposure. And they compared these groups of veterans to veterans who did not work at the burn pits. And so the radius that they decided on was 3 miles. So veterans who worked within 3 miles of the pits compared to veterans who worked greater than 3 miles, with the hypothesis being the closer you were to the pits, the more symptoms you'd have, the sicker you'd be, the more health concerns you'd have. So that was the idea around this particular study. Well, at the end of the study, what they found was this did not seem to be the case. What they actually found was it didn't seem to matter. It didn't seem to matter whether you worked at the pits or not. That there were veterans who worked at the pits who, even if they had symptoms working within 3 miles of the pits, once they returned stateside, their symptoms seemed to improve. And there were also some veterans who worked greater than 3 miles from the pits who had symptoms, but they seemed to have trouble with their breathing as well. So the question became, what else could it be? You know, if it's not just the pits, maybe it's other airborne hazards that are contributing to this, or maybe there's some service members that may be more susceptible to having long-term effects related to exposure to the pits. At any rate, there was something else going on. And so this opened the idea of an alternative phenomenon, right? And that alternative phenomenon was this idea of particulate matter, or PM 2.5. So it opened this idea that it's not just the pits, that perhaps it's this phenomenon or of collective elevated particulate matter that was generated from multiple sources that all of these deployed veterans were exposed to. So smoke from burn pits, of course, is not something you should be exposed to, but also the fine sand and dust, the smoke from oil well fires, and this poor air quality generated collectively elevated levels of PM 2.5. And that's important to know because there were additional studies that went back in time that were able to recreate and create these models that looked at all of these areas where veterans were deployed and generate models of levels of PM 2.5. And then they compared them to these were military levels of PM 2.5. You see this dark line. So the PM 2.5 levels you can see were greater than the military levels in all of these areas of deployment. And then this dashed line is the EPA standards, the 24-hour EPA standards. So again, all of these areas had elevated levels of PM 2.5 when they looked at these area models. And when you think about how small PM 2.5 is, this is a graphic to give you an idea. So now the pink is the PM 2.5. So that's this tiny pink thing. This is a grain of sand. This is a strain of hair. This is this is PM 10. So that's like dust and pollen and mold. PM 2.5 is this small. And this is important because the smaller it is, the deeper it can get into the lungs and cause trouble. So that's the theory that we're working on. So to follow a follow-up to that last study that we had, then looked at two separate groups of veterans, deployed veterans versus non-deployed veterans, to see what kinds of medical conditions that we were seeing in these two groups of veterans. And the most common diagnoses that we saw when we did these diagnoses were really around asthma and then upper airway abnormalities, primarily rhinitis and sinusitis. And they seem to also be related to PTSD, sleep apnea, GERD, smoking, and BMI. Having said that, we were not able to see significant rates of these conditions on their own, but the asthma and upper airway abnormalities, when compared to the general population, consistently seem to be elevated in this group. Trying to watch my time. So the main points is that the majority of veterans with air hazard exposures seem to have resolutions of their symptoms post-deployment. A significant proportion, though, continue to have symptoms. It's unclear if the cause is one or a combination of these exposures. The most frequent diagnoses, however, were asthma, sinusitis, rhinitis. And then, because of the research around this, in 2021, VA granted a presumption for these conditions in veterans who deployed to these areas. Okay. This slide, I'm going to just take a minute to talk about as I watch my time, okay? Is I don't know if there are any folks out there who've been, following some of the news around VA and concerned around exposures. But one condition that came out very early that drew a lot of concern was a condition known as constrictive bronchiolitis, which is a small airways disease that's pretty significant, pretty serious. Now you can see it in the general population, and it has been associated with certain chemicals. In certain factories, but it was seen in a specific group of veterans who were exposed to sulfur dioxide in a certain area of Mosul during deployment in Iraq. And in this group of people who had significant symptoms and ended up having lung biopsies, they found had findings that seemed to be consistent with constrictive bronchiolitis. So a lot of people got worried about constrictive bronchiolitis. Having said that, this was in a very small group of people, like 38. And again, it was a specific exposure linked to this. But because of this concern, VA then tasked us with the Airborne Hazard Center after NASM did this report. Um, Highlighting that we don't have enough information to make any kind of determination, and so they really said, VA, I think you need to take a closer look at this, convene a panel to make some kind of statement. And so then VAs turned to us at the Airborne Hazard Center of Excellence to take a deeper dive into the research and the literature and make some kind of statement. And so we did. And out of that effort, we determined that it wasn't just constrictive bronchiolitis. In fact, is a very, very small population of people that ended up having constrictive bronchiolitis. But even that was difficult because in the gold standard for diagnosing constrictive bronchiolitis is a lung biopsy. And nobody's going to go around just doing lung biopsies on people, especially in this population, because a lot of these folks end up having multiple comorbidities and are actually pretty sick. So, you have to be healthy enough to be able to tolerate a lung biopsy in order to make this diagnosis. But what we did notice was that there are multiple other compartments where disease can occur, and these are some of the diseases that can show up. And so we thought that the better name for these conditions is deployment related respiratory disease, where damage is really confined to multiple components of the lungs. And the majority of the cases that were seen in these groups was actually, again, asthma, rhinitis, and sinusitis, and actually not constrictive bronchiolitis. And these are some of the specific diagnoses that can be seen as deployment-related respiratory disease. And I won't go over all of it for sake of time, but there are specific conditions that can be noted. Again, a little bit of a transition because a lot of people, I think, get confused about too how the VA is organized because VA is the larger department that handles everything that manages veteran affairs, right? Department of Veteran Affairs. But there are three separate administrations. The Veterans Health Administration, which is in the middle, that's where we work, and that's the department that handles everything medical, right? From mental health and medical treatment. Um, then VBA is where all disability issues are handled, and anything outside of medical. And then the third is the National Cemetery Administration, which handles anything burial and memorial. I always put that out just so people understand that there are these three other departments, and although they're cousins, they're not directly related to each other. Okay. And the PACT Act, I don't know if folks have heard of the PACT Act. The PACT Act is a new act that was signed into law in 2022, yes, by President Biden, that expanded care for Gulf War veterans and actually added a number of conditions as presumptive for veterans who deployed to the Gulf War and had exposures to burn pit smoke. Now, I want to talk a minute about presumptions because I mentioned that word a lot. What does presumptions mean? And this is important to understand because a lot of people get confused about what it is. So, why do we use presumptions? So, we use presumptions because um, when I talked earlier about trying to understand how an exposure causes a health outcome, there are a lot of different things that you need to know. You know, how much you were exposed to, when you were exposed to, all these things. During war, it's often very difficult to understand that, right? Because in war, people are moving around a lot, they're trying to survive, to get back home, and there really is no way to figure that out. And so, because VA can't go back in time to figure those things out, they use what's called a two-step presumption to lean in favor of the veteran to decide um, how to manage their care. And really, this is a process that's used for the purposes of service connection and disability rating. So, what are the steps? The first step is, if you were in a known location where they know an exposure occurred, they will assume that you were exposed to that substance. That's the first thing. So, example, and I'm going to go to Agent Orange. That's probably a good one. So, if you were in Vietnam, they will assume that you were exposed to Agent Orange. Okay, that's the assumption they're going to make. They're not going to try to figure out how much you were exposed to. If you were there for one day, for 1 hour, they're going to assume that you were exposed to Agent Orange. That's a fair assumption because we know it was used. The second part of the assumption is if you were exposed and developed one of the conditions that VA recognizes as being related to that exposure, they will presume that you got that condition at least in part because of that exposure. So currently, VA recognizes, I think it's like there's several conditions. I don't remember the actual number. I think it's 20, but well, 20 burn pit ones. But Agent Orange, diabetes is one of them, right? So if you develop diabetes, VA will recognize that, okay, so maybe you got that diabetes, at least in part, because of your exposure to Agent Orange. And so they will compensate you for that, the veteran for that. They'll compensate the veteran for that. What presumptions don't mean is that Agent Orange caused your diabetes. That is not what a presumption means. That's not what it means. In some cases, there may be science that supports that relationship, like I just said about asthma, rhinitis, and sinusitis. But these are legislated decisions, really, where Congress says if you were exposed and you get sick, we're going to take care of you. And that happens, I think, to be the right thing to do. And that's important because as we look at all of these conditions that are now presumptive service-connected conditions for burn pit and what the PACT Act calls other toxic exposures, you'll see a number of cancers here and other presumptive illnesses that VA now recognizes as presumptive service-connected conditions. In addition to asthma, rhinitis, and sinusitis, you see a whole lot of cancers. So what VA is saying is if a veteran who was deployed to those Gulf War regions developed these conditions, VA will take care of them. What this doesn't say is that if you got brain cancer, it was because of burn pit exposure. Currently, we have not seen any significant rates of brain cancer in veterans who had these exposures when they compare that to the general population. We've not seen that. And we've been doing this research for over 30 years. Now, that doesn't mean that veterans don't get brain cancer. They do. People unfortunately get brain cancer. But when you compare the rates in this population to the general population, we don't see significant elevations, at least consistently. And I think you guys may have looked at the Bradford Hills criteria of causation last week. In order for there to be to say that there's causation, you have to meet specific, some of those you have to meet those specific criteria, and consistency is one of them. So you may have one study that says, we think we see something, but you have to have some level of reproducibility. And we've not been able to see that so far for a number of these cancers. Okay. All right. Let me hurry up and move forward. What's going on here? All right. All right. So treatment. So then the next question becomes treatment. And docs, the patients will say, well, doc, how do I manage this, about these exposures? They get really nervous about treatment. And so I try to break it down into two parts, right? Exposure management and actual treatment of the condition. In terms of exposure management, as an exposure provider, the first thing that I tend to try to tell patients is if you're around an exposure that's making you symptomatic or making you sick, remove it. Remove yourself from it or remove it from you, whether that's a chemical, a substance, or a person. If you're around something toxic, remove yourself from it because it's only going to make you feel worse. If for whatever reason you cannot remove yourself from it, make sure you're using protective equipment. Make sure you're using a mask, ventilation, whether that is something at work or if you're cooking at home and you're generating a whole lot of smoke. Make sure you have your vent on. Make sure you have your mask on. And in terms of how we think about exposures, I tend to try to think of them as a risk factor, meaning that um, it's never good to breathe in smoke, whether you're smoking cigarettes or if you were at a burn pit. But just like cigarettes can increase the risk of lung disease, it's not a guarantee of develop. We all know people who smoked all their lives and never developed cancer. So it's the same here. It may increase your risk of having a bad outcome, but it's not a guarantee. And again, remember, a lot of this depends on the dose, the route, and whether or not you have mitigating factors. And remember that a lot of these symptoms will improve or resolve if the exposure is recognized early and removed. In terms of management, in terms of all of the research we've done, what we've not seen is that there's any difference in how you treat your asthma, whether it's related to burn pit smoke or smoke related to you living next to a factory spewing out chemicals into the air on the highway. So you're following evidence-based practices, evidence-based treatment, and using those current guidelines. You're also following the same risk factor reductions and healthy lifestyle changes that we recommend for anybody else: diet, exercise, stress management, and following the same screening guidelines based on your age, gender, and other risk factors. So all of those are important. Now, these are some recommendations that we typically will share specifically for these DRRD treatment. What you'll notice is these are evidence-based recommendations that we specifically will give. And these are just examples and in terms of if you needed help in terms of what recommendations to make. And what I want to point out in here is that when we're talking about constrictive bronchiolitis or other small airways disease, currently there is no evidence-based treatment. So you're really looking at treating symptoms to the best of your ability if we think that's what they have. And I think the last slide before we go back to our case is a reminder of what we call the three Ps. And why is this important? This is important because you have to look at the patient as a whole person, right? So sometimes we get stuck on medications. And so we have to recognize not only predisposing factors, is that people come to you with a history and a background, right? Um, Maybe they had a history of childhood, asthma. Maybe they have a family history that predisposes them to getting sick. They come to you that way. There's nothing you can do to change their genetics that may have predisposed them to getting whatever they have. Precipitating factors. Okay, they genetically are wired to get asthma. And then they went into the military and they had burn pit exposure, right? That has now put them in a place where they have asthma. Now we're at a place where they're perpetuating factors. Are they continuing to be exposed? You can give a patient as many medicines as you want, but if they're continuing to be exposed to things that are going to irritate their lungs, no matter how many medicines you give them, they're going to feel bad. And you have to make them aware, but you won't be able to help so that they know. And I think a good example of this is I had a patient this week. She is allergic to dogs. She's allergic to dogs. She has a German Shepherd that she is allergic to, right? She's on three different medicines for her allergies and her breathing. She's getting allergy sites. And she comes to us, she's like, well, I'm still symptomatic. And what should I do? Do I need another medicine? I'm like, well, actually, another medicine isn't going to help you. You're doing all the treatment you can for your symptoms. It's the dog. So you can get rid of the dog and feel better, or keep the dog and realize that you're going to have some symptoms. That's where we are. And she's like, oh, okay. I didn't know that. So it's and, you can get an air purifier. You can get a filter, a HEPA filter, and maybe that'll help. But it's those sorts of things. All right. So let me move along. Okay, so back to our patient. Right. We're just going to review our history. He's moved to the area. He wants to know if you can help him with his breathing. Right. This is his background. So I'm going to open it up to you guys. So come off mute, and I'm going to ask you a few questions. Right. Charlie, how much time do I have left? if you
You
can.
have you have about 20 minutes left.
Outstanding. Okay, very good. So if you if you guys can come off mute, who joined me first? You're gonna go first. Mitchell. Ah,
All right.
Mitchell, come on. This is easy. So Mitchell, we're looking at our patient here, right? 57-year-old male just moved to the area, comes to see you, he wants to know if you can help him with his breathing. So we everything I've just said to you, right? These are his
Yep.
medications. He's a never smoker. He drinks on the weekend. He's a mechanic. He's a Marine that deployed to the Gulf War. Is there anything you would want to ask him? Um, that anything at all, and no question, nothing is wrong. Nothing, there's nothing you could say that's wrong here. What would you want to ask him?
Yeah, for sure. With the Gulf War, like, was he living near the burn pits or was he exposed to them?
Wow, that's a great question. See, you get an A already. Exactly. You want to ask this man more about his experiences during his deployment. You want to know more about his exposures, right? Anybody else? Anything else you want to know, especially about his maybe about his current occupation? Anybody have a question about his current occupation you might want to ask? Dun, 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 dun. You can shout it out.
Well, he is
Yes.
Does he
mechanic.
use personal protective equipment?
Oh, I love it. Is he wearing any protective equipment? And if we're asking him about protective equipment, what we really want to know is he around any other substances that could be making his symptoms worse where he would need protective equipment? Excellent. Very, very good. Wonderful. Okay, so I'm gonna go to the next slide, right? Let's see. We're gonna get some more history here. I don't know why this thing does this to me. Behave. Behave. All right. So now, because we're occupational medicine doctors, we get some additional occupational medicine history here. All right. So this is my specialty. This is what I do. So he's a 57-year-old Marine veteran who wants to know about his breathing problems, and what he really wants to know is, are they related to his military exposures? So, from his civilian history, he was actually born at Camp Lejeune. He joined the military when he was 18 years old. And again, he's a lifelong smoker. In terms of his military history, his MOS or military occupational specialty is he's a wheeled vehicle mechanic. He deployed to Iraq for 18 months. He started having symptoms during his deployment, and they have progressively worsened over time. Now, after the military, he served for 30 years total and separated. But he continued to work as an automobile mechanic, and he has his own shop where he started out working on his own, working on the cars, working with the chemicals there. But because his symptoms continued to worsen, he was ultimately again diagnosed with asthma, was on medications. Now he needs medications all the time, and he's also been recently told that they think he has kidney cancer. So, has anybody on here heard about Camp Lejeune? Just shout out yes or no if you've not heard about Camp Lejeune. Has anybody heard about Camp Lejeune?
Nope.
No.
Nope. Oh no.
I've heard the commercials that say you're entitled to financial compensation. Yeah.
That that is right. There are commercials, they send out emails. People are yeah, yes, yes, yes. So Camp Lejeune is a military base. It's called a garrison base. So it's in garrison bases are typically US bases, and this is where veterans go to train. So he was born at Camp Lejeune because his dad was also military. Right. So I say he joined the army. That's not right. He actually was a Marine. His dad was oh no. Go back. Go back. We're not there yet. Yeah. So he was born at Camp Lejeune because his dad was in the military. And so his dad and mom, they were stationed there. So that's why he was born at the base because that's where his dad was. So they moved there. And this is actually very, very, very common. So Camp Lejeune is a base that is known to have been had contaminated water there. And the water was contaminated with solvents, and it was contaminated by a couple of sources. The primary source was an offsite dry cleaning company. And unfortunately, this is actually a very common phenomenon in this country where companies will it's better now, would dispose of chemicals into the water supply, and that then would get into the community water, make its way into well systems that made then its way into your homes, and you use it to cook, to shower, to drink. And that's what happened here. Now there were also some underground tanks that had been buried with fuel, and it started to seep out into the ground. And that too is a very common way that they would deal with old fuel. So that's how it got into the system. I think you guys talked about some of these chemicals last week, but that's what happened. That's what happened there. Any questions about anybody interested in any questions here? You don't have to have any, but I'm just opening it up. Any questions about this before we move to the next slide? Because we have more.
When did he develop his app?
I love that. So the symptoms again when he was in the military, and I'm going to tell you this on the next slide. So let's set it up for here. So when he was deployed, although he's a mechanic and his job, he was trained to be a mechanic, right? So he was supposed to be working on cars. That was his job. He was supposed to be working on changing the oil and fixing the cars and the military vehicles. But it's very common that veterans get assigned to do other duties. So when we're asking veterans, well, what was your MOS or what was your job? You need to also ask them, what did you do? What else did you do? So he was also assigned, in addition to being a mechanic, he was also assigned to man the burn pits. So he would, so what I was describing earlier, where he had to go and they were responsible for pouring the JP8, the jet fuel, onto the trash, light it on fire, and burn it. And he was also tasked with what I call latrine duty. So they had outhouses, and somebody had to get rid of that waste. He was one of those people. They used a special concoction to set that on fire and get rid of it. So he did that too. And so all of this was in addition to him working as a mechanic, which was outside work. So he was caught in quite a few sandstorms and dust storms. So when you hear this, based on what I was talking about before, what do you think about that exposure? And yeah, what do you think about that exposure? Let me not give it away. What's the commonality? What's the thing that ties all of these together? Dun, 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 dun. Has a number tied to it. Elevated levels of what? Very small.
PM 2.5.
Excellent. PM 2.5. All of these together generated extreme levels of elevated PM 2.5 for this man. So you ask, when did he develop asthma? He started having symptoms during his deployment. And this is the other thing about military folks, right? Is he was getting short of breath. He was coughing coughing a lot, and the body has its own natural defenses. It has nasal hairs, it has a cough reflex. The body will try to get rid of stuff that's not supposed to be in it. The body's built in an amazing way. But because the PM 2.5 is so small, it will bypass those natural defenses. And so, they'll tell you, they were coughing up black, soot, black snot. They were, snotting out stuff that looked like black snot. And that is true. So, but this stuff gets past all of that into the lungs and can cause trouble. But even though he was symptomatic, the next question tends to be, what they'll usually get asked is, well, did you go to the doctor? Did you had this difficulty breathing? Did you go seek care? And they'll say, well, no, I didn't. Well, the culture around military, service is you're really not encouraged, is the word I'm going to use, to seek care, especially during deployment. Because one is they don't want to leave their unit shorthanded. They're trying to look out for each other. And then there's this thing where I can tough it out, but I think the bigger thing is he was there for 18 months and they're trying to get home. They're so my dad was in the military. He called it being cocked. They're so on, right? That oftentimes they don't even realize they're sick, right? They're trying to make sure that if there's a mortar that comes in, they don't get hit. They're trying to make sure, if somebody's driving in with an IED, they don't get blown up. Sometimes they don't even realize that this coughing I'm having is getting worse. They don't realize it until they get back and the coughing doesn't go away. So he didn't seek care, and then again, they have a saying: they don't go to sick call or to see the medic unless they're dead or dying. They got to be really, really sick to seek care. So he didn't, although he should have. So that's there. So in terms of the other history, pre-military, again, he was a military kid because he grew up on the base. And also, just so that his mother has now been diagnosed with lung cancer. That is thought to be related to Camp Lejeune. It is one of the conditions that VA recognizes being associated with that exposure. And so now he's also worried about Camp Lejeune long-term health effects. And I'll talk about that in a minute. And then post-military, since he separated, he really is worried that his military service has made him sick. He finally came to VA. He was worried a long time, and it took a long time for him to come to VA. And then when he did come, and he was talking to his doctor about this, he felt like the doctor was saying, you know what, it's you know have you talked to somebody about this? He felt like he was being told it was all in his head. And the other thing that's not talked about a lot is, you know, veterans are trained, military servicemen and women are very they're trained to be good fighters, right? Um, a lot of times they'll say they're not trained well on how to transition back into civilian society once they separate. So they're not trained well on how to talk about their feelings or their emotions. And so it typically can show up looking like anger. And so oftentimes what he was told was, if he was looking irritable, that he had anger management problems, which really made him angry. And so he started drinking to self-medicate, which then became a problem. So it almost became a self-fulfilling prophecy. So he was finally diagnosed with PTSD, and it was recognized that he had trauma from, the work that he did and when he was deployed, because 18 months is a long time for you to see dead bodies, to hear mortars, to be worried you were going to die. He was diagnosed with PTSD. He got into mental health, and it was recognized that he was sick. He did have asthma. He had other medical issues that were completely separate. You can have two things can be true at the same time. You can have anxiety, depression, PTSD, and have asthma, and have difficulty breathing. It can all be true at the same time. So what do we do for him? So we break it down into his asthma. So when we look at his asthma and we think about the PACT Act and all of that, and based on the science, he had multiple airborne hazards exposures that are more likely than not the cause of his asthma because of the PM 2.5 we talked about. How do we manage it? With evidence-based evaluation and treatment. Because of PACT Act, VA sees that as asthma as being presumptive, so he should file a claim with VBA, where VA will cover the cost of his medications and treatment. In terms of other exposures of concern, for mechanics, the typical exposure is solvents, degreasers, fuels, gas, all of those. He should make sure that he's using protective measures, because there are a lot of different solvents that can cause a whole lot of other issues. We don't have time to get into it today. In terms of Camp Lejeune, for Camp Lejeune, there's a number of conditions that VA recognizes as being related to that exposure. Kidney cancer is one of them, so he can also file a claim for that as a VA presumptive condition for him. There's also a program for family members. So for his mother, lung cancer is one of those conditions. She can file for that program and get. They will cover out of pocket expenses. It's not an insurance program, but they will cover out of pocket expenses for her. In terms of how you manage these, you tell them to follow screening guidelines. Because people say, well, how do I know if I'm going to get these conditions? You follow the same screening guidelines. We don't do new screening. The biggest question we'll get is, do you screen for lung cancer or lung conditions because of burn pit exposure? The answer is no. And why is that? Because there's no way to measure burn pit exposure like you measure cigarette smoking. You got to be able to measure it, and you got to know what you're looking for in order to use the screening protocol. And then, of course, PTSD and mental health stressors. We want to make sure we connect him with mental health support, veteran support groups, and other veteran service organizations. We always give them the veteran crisis line. And there are also services for the family members, and we give them the 800 numbers. In terms of education for providers, in the Airborne Hazardous Burn Pit Center of Excellence, we created this provider toolkit that is available to walk them through the process for veterans who report difficulty breathing, shortness of breath from the history, the physical, and the testing. That's the QR code for that. And then there is a joint project that we at the War-Related Illness and Injury Study Center, which houses airborne hazards. We work with ACPM, which Charlie is a part of. We're proud, and I'm in, well, not Charlie, but we partner with them on occasion. We are ACOEM, but we are all partners together in terms of promoting preventive medicine, whether that's an occupational environmental medicine or promoting just better health for the public and for workers. So this was a project that we partnered with to share information around military environmental exposures. That's free for anybody that's interested. And if you are interested, I can get this information to you. So, in summary, military service is associated with multiple environmental exposures, including deployment related PM 2.10 that we know is associated with respiratory symptoms. Exposure alone does not equal causation. The Airborne Hazardous Burn Pit Center of Excellence has been created for us to better understand these things. Best practices is used to screen, diagnose, and treat these military exposure related concerns. And though a lot of research has been shown that increased risk of post deployed veterans have developed rhinitis, sinusitis, and asthma. Ongoing research helps us to understand that this phenomenon of deployment related respiratory disease is probably the best way to capture and describe what we're currently seeing. So that's the end. I want to transition to our Kahoot. We have time for that? I think we do.
Yeah, I think as long as anyone who's on the call still has time to participate in the Kahoot, we should be
It'll be
okay.
it'll be pretty quick.
Yeah,
Pretty quick.
excellent. Excellent.
So let me just open it up. Let me move to that screen and then Kahoot. You guys have to be patient with me. This is my first time doing one. My son helped me last night, but I'm going to open it up, okay? Toxic skies. Start. Ready to, it says loading the pen. Okay, so I'm going to share the screen so you guys can see the pen. Do you guys see it?
Yes.
So guys, let me know when you're ready. I love your pictures. They're awesome. So I can't tell if it's everybody, but do I need to wait any longer? Can we get started? Corinne, are you there?
I'm on.
You're on? Okay, so I'm gonna go ahead and see if I can start. I hope I'm doing this right. Okay. So which of the following is considered a type of airborne hazards? This might be too much time, but I'm giving you a minute for each one. Everybody answered. This is outstanding. That is correct. Sand and dust. Does anybody want to tell me what some of the others are?
I think you mentioned yellow mustard during the lecture.
I didn't mention yellow mustard, but that's a good one. That's a good one.
The particles from the oil, like when they exploded the oil.
Yeah, oil well fires. Exactly.
Oil.
Oil well smoke from oil well fires. Of course, burn pit smoke, general air pollution. Mustard gas would probably be more closely related to chemical weapons. Sometimes people will think about that as an airborne hazard exposures, but we think of that more as a neurological kind of agent. Okay, so next question. Ooh, very good. Okay. Next. Which of the following conditions is not linked to airborne hazard exposures? Never has based on scientific evidence. Which one is not? And I hope y'all like my little pictures. I don't know if y'all recognize them, but fantastic. So the correct answer is lung cancer. Lung cancer is not linked to airborne hazards based on scientific evidence. Based on the science that we know, it's asthma, chronic rhinitis, and chronic sinusitis. Okay, next answer. Next question, rather. Awesome. 3 of 5. Which of the following is a way to manage airborne hazards related health conditions? Do nothing and hope for the best. There's no treatment anyway. Seek special military medical care. It's all trauma related, so talk to a mental health specialist or follow evidence based practice guidelines. Everybody got it right. Outstanding. Okay, next one. Well, which of the following is true? Association does not equal causation. All military exposures are toxic. Presumptions are based on individual exposure monitoring, or all routes of exposure cause the same symptoms and conditions. Outstanding. Association does not equal causation. There are many criteria that have to be reviewed before you make that determination. Good job. And the last one, which is not one of the 3 Ps? This is going to get you. Perpetuating factors, precipitating factors, preoccupying factors, or predisposing factors. Dun, 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 dun. The correct answer is preoccupying. Perpetuating are the things that continue the symptoms. Precipitating can start them. Predisposing are what you're born with. Very good. Outstanding. Janessa, Janessa. I don't know who TT is. Number 1 is. That's so cute. Is that Esme? Esme?
Yep.
Awesome. Well, thank you guys. That's awesome. Charlie, what's next?
I believe that that concludes the programming
Yeah,
for today's session. I can't thank you enough, Dr. Robertson, for taking the time to host this.
yeah,
I think it's
yeah.
been absolutely wonderful and kind of shows an in-depth look at some of the issues impacting our service members. So thank you so much for taking your time. Thank you, Dr. Obi, who I believe had to jump off, but for joining as well, and for all of the students who were able to join today's session as well.
Yep. I think I don't know if there's a message here. Let me see. Oh, you lost my audio? Oh, was there anything that I missed? I'm happy to
No,
answer.
Dr. Robertson, I think you just cut out for, I mean, I think about like 5 seconds or so.
Okay.
It wasn't
Okay.
anything too bad.
Okay. Very good. Well, it was wonderful to meet you all. Thank you so much for spending some time with me today. I hope you guys will join us again next week where the adventure continues. Have a great day.
Thank you
Thank you
so much,
guys.
everyone. Thank you again, Dr. Robertson. I really
Thank
appreciate it.
y'all. Have a great day. Bye bye.
You as well.
Mhm.